There'll be a few different things going on. We'll try to make up the time. So we'll squeeze a few things, a few places. And we want to talk together about how we'll most effectively move from evidence to implementation to face the kinds of public health challenges that we share together around the world. So with that introduction, I would like to call up Anne Kamau, who is here speaking on behalf of Paul Kamau, who is the Director of Research for the Institute of Development Studies, or Institute for Development Studies here at the University of Nairobi.
Hello, good morning, everyone. And our online participants, wherever you are, good morning, good afternoon. Thank you, Heather, and thank you, Pascaline, for this great opportunity to welcome all of you to the Institute for Development Studies as I speak for Professor Kamau, our director. I am a sociologist myself, as I speak also for IDS, which is a multidisciplinary institute, and also I am from a public health background. So this summit is relevant in very many ways. Simply, first because I'm a member of the IDS, and also because I am also where I actually belong. So the Institute for Development Studies is an old institute established in 1965, multidisciplinary institute covering several areas. That is the area of institutional governance and development. We are in the area of social inclusion, health, and development, and this is where this summit falls in as we think about vaccination, uptake, and also issues of cost and all of this. We also have a very strong component on transport, enterprises, and development as a core component of IDS research. We're also looking at research on governance and political engagement. Again, as IDS, the Institute has both a master's and PhD program, and we know that as we think about the next generation of scholars, we need to think about capacity building of young masters and PhD students. So my role is really to welcome you to this summit on behalf of IDS. And I would say that as we think about the vaccination programs and whether uptake or slow uptake, and from a social science perspective, that we need to think about several issues from where we sit in IDS, that we need to think about the Africa priority in terms of vaccines. Perhaps what you're pushing for right now is HPV vaccine, which is probably targeted to the young, especially the young women. But is that necessarily the African priority? If it is not, how do we make this HPV vaccine to fit within the African priority? Again, what are the missed opportunities related to vaccine? And I would want to remember a situation last year where we had a team of us who were going to Germany post-COVID-19, and we had engineers, young students from IDS, engineering department, and we really wanted to support these young students to travel, to experience from the Karlsruhe in Germany experience of how they're engaging with the government in promoting walking and cycling in the city of Karlsruhe in Germany. But one of the students, one of the engineering students, opted not to travel because he did not want to take the COVID-19. So that is a missed opportunity in our case. But because many times when you think about vaccine, you think about education. This is an engineering student, so we need to debunk education and vaccination from a social science perspective, that there could be more than education in terms of uptake and acceptance of vaccination. Again, misinformation, of course, is a big issue, and I've read the documents from the Mercury program, and this is one of them. But beyond the vaccination, the HPV vaccine some time back was really a big thing and was promoted. But how do we sustain the momentum? I no longer hear about the HPV vaccine. I had the advantage of working with one of master students on uptake of HPV vaccine among women in Nairobi, low-income areas. But I don't hear it anymore. It's not that much. So how do we sustain this momentum in terms of how we encourage uptake of vaccination. Is it a one-off and then it goes down, or how do we maintain this momentum? Then for us, from the African context, how much vaccines can we take? How many vaccines per individual? How many vaccines can the body take? I think it's something we need to think about as we think about the vaccination. A forgotten lot are the ones who actually have to take the vaccination, the HPV vaccine, maybe the young girls, the adolescents. How much are we involving them? In my studies, I argued that the owners of the body are many times not involved. How much are we involving the young people, the people that want to take the vaccine in the in the vaccine programs, as much as we think about uptake? And then, of course, from African, the social cultural perspective, the referral system is very strong. What we might want to call the social vaccine. How are we dealing with the social vaccine, which is also a very strong component in terms of influencing uptake, religious institutions influencing uptake. These are very many, very heavy issues that we need to think about. How, what is the role of the caregivers in all of this? So that's what I would say from the IDS side as I welcome you to this summit, but also to mention that I'm also representing on the other side, I wear two hats. I'm also the Deputy Director of the African Research University Alliance, Arua Center of Excellence for Non-Communicable Diseases. And again, within Arua, we are focusing on prevention as one of our key pillars. And Arua, the hub, we have the Center of Excellence, also which is a member of the Africa-Europe Clusters of Research Excellence. And we are hosting the hub on NCDs and multimorbidity. And again, this is an area where we think that we can work across with the team in terms of understanding how does vaccination even help to prevent global health programs, challenges, sorry. So I would say that we welcome you to IDS. We welcome you to the Arua Center of Excellence or the Africa Cluster of Excellence for Research for NCDs and morbidity. And to say that we are very, very delighted to have you here. We are very honored as IDS to have to host this summit and look forward to even long-term and future engagement as we think about the future of vaccination in Africa, not just in Kenya, in terms of uptake, but more importantly, also focusing on those that we really target to take up the vaccination and in terms of community engagement. Allow me now to humbly invite our Dean, the Dean of Faculty of Arts and Social Sciences, Professor Jack Othiebo, to again welcome us on behalf of the Faculty of Arts and Social Sciences. Feel welcome and be part of the University of Nairobi. We are proud that you give us this opportunity to host you. Thank you very much.
So good morning, everyone. Professor Gitau, Deputy Vice Chancellor Academic representing the Vice Chancellor, Dr. Anne Harvey, President of the Research Council, Dr. Anne Kamau, representing the Director of IDS as well as Arua, and all of you researchers, students, guests from outside. I've said good morning, but I wish to welcome you to the Faculty of Arts and Social Sciences, in which we have the IDS. It's a big faculty with 14 departments, with different disciplines. Many of them collaborate with the IDS in doing research. IDS itself is an institute that has produced several Nobel Prizes in economics. If you read history, you'll find them. So I hope that among you, we will have other Nobel Prizes from the researches that you are doing. So without much ado, may I welcome the Vice Chancellor, represented by Professor Ayub Gitau to give his speech. Thank you.
Good morning. I'm from the engineering discipline, and when the directors talked about an engineer refusing to take the vaccine, I wondered what was the problem. But anyway, we know what was happening. Receive welcoming remarks from our Vice Chancellor, Professor Margaret Hutchins. She's out of the country. She had traveled this week. But then we are here representing her. And she passed our regard. I hope you have received her greetings. Yes? I hope you received the greetings from our Vice Chancellor. Okay, thanks. So we have Abdul Said, Director, Department of Health, Human and Veterinary Services, Wayne County. And you have the President, Social Science Research Council. Hilda Lanthorn, Director, the Mercury Project, Social Science Research Council. Umuriza Njiro, Director, Communication, Policy and Advocacy, the Rockefeller Foundation, Africa Regional Office. The police Senior Advisor, Social and Behavior Change. Vikesh, Clinician Scientist, Google and YouTube Health. The Dean of Social Arts and Social Sciences, Professor Jack Odhiambo, and the Director, Dr. Anne Kamau, esteemed members of the University of Nairobi. And most importantly, our students, ladies and gentlemen. It is an honor for the University of Nairobi to host the Mercury Project Solution Summit. This gathering is an embodiment of our collective commitment to addressing some of the most pressing challenges of our time, particularly in the area of public health. Today we reflect on the role of academia, the broader research community, and the industry, and our responsibility in shaping solutions for critical health behavior, especially in ensuring the uptake of protective measures like vaccination and the delivery of reliable evidence-based health information. Allow me to warmly welcome the Social Science Research Council, with whom we have partnered and engaged before. As we gather here, I would like us to consider the profound role we, as an academic institution and the premier institution, have in influencing the trajectory of public health outcomes, not just through research, but through collaboration with the public, the private, and philanthropic sectors. At the heart of our discussion today is the question: how can we bridge the gap between the discovery of promising health solutions and their real-world implementation? So more or less, we are talking about the research industrial nexus. Universities have historically been the bedrock of research and innovation, and at the University of Nairobi, we pride ourselves on a legacy of contributing groundbreaking research across disciplines. And today we face an unprecedented opportunity and responsibility to advance solutions that can save lives. But let me be clear, conducting research is not enough. Our role is broader. It is about ensuring that research findings don't gather dust in academic journals, but are translated into policies, programs, and interventions that improve lives. We are not merely knowledge producers. We are change agents and change makers. We are responsible for training the next generation of scholars and professionals who will not only engage in research, but understand its practical application in society. We are responsible for ensuring that what we discover in our laboratories, our classrooms, and field studies does not remain theoretical, but becomes the foundation for action. The Mercury Project is a testament to solutions-oriented research. focusing on innovative ways to improve public health behaviors. As an academic institution, we are uniquely positioned to train and mentor researchers, practitioners, and leaders who will continue this vital work. It is our duty to equip our students not only with the technical skills to conduct research, but also with the ethical foundation to ensure that their work serves the greater good. Students, as you sit here today, you must understand that you are part of a much larger ecosystem. What you learn within this world can and should be applied to solve real-world problems. You are the future custodian of health knowledge. You are the bridge between academia and the communities that need our help. However, universities cannot do this alone. The public, private, and philanthropic sectors all have critical roles to play in adapting and implementing the solutions that research reveals. The process from discovery to delivery requires strong partnership, partners that transcend the traditional boundaries of academia. It is only through collaboration with government agencies, healthcare providers, businesses, and civil society organizations that we can ensure research has a tangible impact on the society and the people. We need to engage with the policymakers to ensure that they have access to the latest scientific evidence when making decisions about public health. We need to work with healthcare providers to ensure they are equipped with the best tools and practices to promote behaviors like vaccination. And we need to collaborate with the private sector and philanthropists who have the resources to scale solutions quickly and effectively. As we discuss health interventions over this period that we are here, one of the most crucial issues we face today is the need to improve the uptake of protective health behaviors, again, such as the vaccinations. We all witness the global disruption caused by the COVID-19 pandemic, and in many ways, it served as a reminder of both the power and the limits of scientific innovation. Vaccines were developed at an unprecedented speed, yet uptake was varied. We saw how misinformation and fear influenced people's decisions, sometimes leading to devastating consequences. We must ask ourselves, why is it that even when we have the solutions, they do not always reach those who need them most? The answer, I believe, lies not just in access to health care, but in access to trusted, high-quality information. Remember, here we are talking about our multidisciplinary approach, be it with the scientists and the social scientists. If we think about the STEM element, we have also to bring in the social aspect, and normally sometimes we talk about the soft skills. We can have the innovations, but without the social, cultural, and economic intervention, the technology will not go far. Today we live in an era of information overload. With the rise of digital platforms, the spread of misinformation, particularly health misinformation, has been one of the greatest threats to public health. False narratives about vaccines, for instance, have eroded trust in life-saving intervention, leading to unnecessary illness and death. This is where we, as a university, must take a stand. We have a critical role to play in ensuring that accurate, evidence-based information reaches the public. We need to train not just healthcare providers, but communicators, journalists, digital influencers who can help shape public perception and fight misinformation. It is up to us to develop new ways to communicate complex scientific ideas in a way that is accessible and understandable to all. Now, let me take a moment to reflect on why all of this is so critical. The health of a nation is the foundation upon which everything else is built. Without a healthy population, we cannot hope to have productive economies, thriving communities, or even stable societies. The fight for public health is not just about treating diseases, it is about ensuring the well-being of the entire population. It is about giving every person, regardless of where they live or what they do, the opportunity to lead a healthy life. As a research institution, it is our responsibility to contribute to this cause. We must strive to ensure that the health solutions we discover are implemented and that the knowledge we generate is used to foster trust, educate the public, and ultimately save lives. So as I close, I leave you with this call to action. Students, researchers, members of the University of Nairobi community, I urge you to embrace the responsibility of not only generating knowledge, but ensuring its application. And engage with the world beyond the university walls. Be a force for change in the public, private, and the philanthropic sectors. Advocate for the use of science-based solutions and fight against the spread of misinformation. The future of public health is in our hands, and we must seize this moment to create a healthier, more informed, and more resilient society. Together we can transform our research into action, and action into lasting change. Thank you, and let us continue this important work with a passion and purpose, and God bless you. That's our speech from the Vice Chancellor. Yeah, thanks a lot, and I'm sure our visitors, as you interact with our various communities, also feel free to visit our national parks. We have one of the rare national park in the city. I hope you have already visited it. And interact with our community. We have also national park, feel free. So now it is my honor to invite the President, Social Science Research Council, Madam Anne Hafi.
Thank you, Deputy Vice Chancellor. And it's on behalf of the Social Science Research Council, it's my honor to thank the Institute for Development Studies and the Faculty of Arts and Science and the University of Nairobi for hosting us here. We've worked in the past with IDS and the University of Nairobi, and it's so nice to be able to come back here. So what I wanted to do briefly before we start the plenary panel is just give you a little bit of history about how we've got to this point this morning where we have brought you all here together. And the history for us, for the Mercury Project, starts in the summer of 2021 when we were still in the middle of the COVID pandemic, but through a miraculous and remarkable scientific achievement, we had safe and effective vaccines. Those vaccines in the summer of 2021 weren't yet available everywhere all at once, and at that time, much of the attention of the global health community was focused on getting those vaccines distributed more widely. But what we were seeing in the places where the vaccines were starting to become available in spring and summer of 2021 is that we weren't converting enough of those vaccines into vaccinations to be able to reach the targets to provide community protection that we needed. And in the early days, I don't know if you remember this, in the early days, the response of many to this emerging problem of non-vaccination was to blame the non-vaccinated. So you saw commentators and public figures saying things like, the vaccines are free, they're safe, they're effective, it's your own darn fault. If you haven't gotten vaccinated, you will suffer the consequences. And, that kind of rhetoric, it wasn't helpful. It wasn't getting people vaccinated. But from the standpoint of a social scientist, it was also just flat out wrong. It was incorrect. Because getting a vaccination is not, in fact, free. right? The vaccine itself might be made freely available, as they are, and most vaccines are in public health systems. But the act of getting a vaccination imposes a number of costs. There's a price to vaccination, and it's individuals who, in the absence of any kinds of interventions, have to pay those costs. And I'm talking about things like we have a limited amount of time and attention and cognitive resources to, find accurate vaccine information, to sort through conflicting sources of information. And then even once we've done that, there's the transportation and the childcare, logistical costs, and taking time off work. So all of these things are costly. And what we were doing in the early stages of the pandemic was essentially blaming people for not having enough resources to be able to pay those costs of vaccination. So the Mercury project, which the name derives from the Roman god of communication, Mercury, because we thought much of the problem, many of these costs are about communicating information. The goal was to take that framework of vaccination as a costly act, frame up as many of the costs as we could, as a community could think of, with the goal of them being able to design interventions all along the pathway that would reduce costs. So I think that was one of our primary intellectual contributions to the communities that are working on vaccine demand, is to think of it as, okay, it's a costly act, but there are things that we can do to reduce costs, which is how we frame the approaches of the Mercury project. What we wanted to do was we wanted to support research that would look at interventions, test them, that could reduce some of these costs, but importantly, and I'm going to echo the Deputy Vice Chancellor here, our goal was not just to write academic papers. We, of course, love academic papers. It's how science works. We all write academic papers, but we were facing a crisis, and I think we're still facing a variety of vaccination crises, and we wanted to see the research that was getting funded not just published, but also implemented into practice, into policy. And it turns out there's an emerging research literature about how do you design research projects such that you increase the probability that evidence is adopted into policy. And so there were five principles that we used to design the Mercury project. I'm just going to say them quickly because I think it's important. The first is that we know that development programs are more likely to be adopted into policy when there's rigorous evidence underlying the intervention. And so we asked for where we could get it, experimental or really high quality quasi-experimental work. We know that out of all the evidence that we produce as academic social and behavioral scientists, the academic evidence that we produce is more likely to get adopted into policy if we partnered with implementing organizations in producing that evidence, whether it's NGOs or it's governments or it's private firms. And so again, we looked specifically for teams that were able to develop partnerships so that there was a client at the end of the day. There was somebody an organization, if the intervention was successful, would adopt the intervention into policy. We know that evidence is more likely to get adopted into policy if there's a local expert, and we were fielding and funding studies all around the globe, and so that was another requirement, is that teams have local academics, local experts on research teams. And then the two that we're now starting to, those were all in the design phase. We're now starting to grapple with. Several of our speakers have already mentioned communication. There's some really good RCTs on providing evidence to policymakers, the way in which you provide it. So providing multiple simultaneous estimates side by side with simple metrics. Maybe some of you've seen the marginal value of public funds that's been developed out of MIT. It's a really simple way of providing a comparable metric. So we're working with the team to try to provide standardized ways of reporting results. And then finally, we know that even when you partner with implementing agencies and you've done the rigorous work and you've done the communication, there's still something like 70% of successful interventions based on evidence that don't get implemented. And it turns out that a large part of that is that organizations just face implementation challenges. Maybe the intervention, they need to change something about their existing workflow, and that's not going to happen naturally. So we're also thinking about how do we extend the partnerships of our research teams with their implementing partners through. We don't just leave when the research study is done. We continue to work on implementation. So that's how we got to the plenary panel this morning. And right now, I think, and what we're hoping the plenary panel can help us grapple with are some questions about where we are now today. So, is vaccination still a problem? And if so, where and in what way? Do we still, have largely emerged from the COVID crisis, but where and how do we still face emerging vaccination problems? Anne mentioned HPV as being a particular problem that I think many of us are concerned about. And the second is, what do we know now that we didn't know 3 years ago when we first stood up the Mercury project? What has changed in terms of the evidence base in particular? And then third, particularly from our panelists who are running or working with organizations that deliver health services, what are the implementation challenges that organizations are facing now in terms of supporting vaccination uptake? So we are thrilled to be here at the University of Nairobi with the Institute of Development Studies, with all of our researchers from the Mercury Project, with all of the students and faculty. Thank you so much for having us here. We're looking forward to a fantastic morning, and if you're staying with us for the workshop, a fantastic couple of days, figuring out how we can better address vaccination challenges. So thank you, and with that, what we are going to do now is we will exit the stage, and I'm going to invite the plenary panel to come and sit, and then Gary Gamayo, who is health lead for Rockefeller Foundation Africa, is going to introduce the plenary panelists. So thank you so much. Oh, okay, I'm sorry. The summit is officially open. There we go. Okay, good.
Check 1 2 1 2. Good morning, everyone. Thank you, Anna. The Faculty of Arts and Sciences, and thank you to the University of Nairobi more broadly for inviting and hosting us for this event. My name is Gerishom Gimayo, and I work for the Rockefeller Foundation. Before I introduce myself, I will let our very esteemed panel to introduce themselves. As Professor Anna said, we want to have a discussion around the current state of the vaccination environment, We want to dive a little bit deeper into the information environment around vaccination, where there are opportunities, where there are challenges, what we know about those opportunities and challenges as we try and figure out what solutions are available to us as a public health community. So I'll start with inviting Abdul to introduce himself, tell us a little bit about his very broad experience across public service, across academia, with a brief stint in politics, and tell us how that experience has shaped his understanding of public health communications. Over to you, Abdul.
Thank you so much, and I just want to echo thank you for such a warm welcome to this lovely space, and looking forward to the conversation. My name is Dr. Abdul Al-Sayed. I am, by training, a physician and epidemiologist. I began my career as a social epidemiologist. My work was focused on trying to understand social disparities, mainly in birth outcomes and chronic outcomes in the United States and other high-income countries. I then got this opportunity to rebuild a health department in America's poorest city, which is the city of Detroit in Michigan. Spent a couple years doing that, and that was an eye-opening experience about trying to translate the work that we had been doing, trying to pick apart the mechanisms of social influence on disease into an actual setting in a real-world space. And then I ran for office, which was kind of a crazy thing to do. We had this guy elected president who probably shouldn't have been president. I'm gonna let you guys figure out who that is. And at one point I was like, okay, well, if that guy can get elected to president, I probably get elected to something. Turns out that wasn't true, but I ran for governor of Michigan. And Michigan is this really interesting microcosm of a state. For folks who are from the United States, you know, we're one of those bellwether critical swing states. For folks who are not from the United States, really, let's just hope that Michigan does the right thing in November. And it was the first time that I had ever thought about having to communicate against an opponent. I want you to all think about that for a second. In this room, the way we think about how we communicate is that we want to be experts on a particular area, and then we want to faithfully and comprehensively convey the information that we know out to the public. That is kind of true in politics, except for there is an opponent who wants to say something else and wants to say that your version of what you're saying is the truth is actually not true, and their version is true. Now, in politics, obviously, we're dealing with ethical, moral issues, in which case there's not one capital T truth. There's different takes on what you should do about the truth, at best, right? There's also lies. That's a different thing. But in what we do here, we try and very faithfully execute what it is that we know to the public so they can make great decisions. And it's the first time, I think, for most of us, that we've ever had to think about communicating against an opponent. And that experience I've had to put back into practice now as a health director for Wayne County, which is Michigan's largest, most diverse county, where I lead a pretty comprehensive department. So I bring that weird, so for the social scientists, I have like a case crossover design in my own thinking about communication, which is learn how to learn things, then apply those things you learned, then go to a place where all of a sudden you have to communicate against an opponent, and then come back and try and apply those things. So I really look forward to the conversation and learning from my fellow panelists. Again, thank you so much, Gary. I look forward to the great conversation.
Thanks, Abdul. Hi, everyone. My name's Vic. I'm a clinician scientist at Google Health in YouTube Health out of London. I've also had a slightly atypical path into my current role. So I started off as an academic vascular surgeon back in 2014 and was on a very, very sort of traditional path, you know, living the sort of Sri Lankan parent dream of trying to become a professor of surgery and make my parents proud. Disclaimer, I am not a professor of surgery and they don't really understand what I do at YouTube. But what I ended up doing sort of during the pandemic was, in addition to working as a surgeon, I worked in critical care, I worked in outreach facilities where, much like Abdul was saying, I came across some very tangible challenges around how you go about communicating what you think is right and what you think is evidence-based to members of the community, folks in hospital, loved ones, family members. During this period, I undertook some research as part of a PhD program around how does one go about communicating high-quality information, what makes for engaging, kind of quote-unquote sticky content, as it were. And as part of that experience, I was fortunate enough to actually move over to sort of private sector in Google and YouTube, where I now lead clinical efforts across Europe, Africa, and the Middle East. Again, it provides this kind of a second perspective on how one goes about kind of using evidence, using sort of medical and scientific consensus in a manner that is actually tangible and sticky to the people that we're trying to serve. I think we have a lot of preconceptions as clinicians that what we say should just get done, but there is a manner in which information should be communicated and is best communicated. And I'm trying to do my part from the Google YouTube side with respect to that.
Thank you, that was great. But I just wanted to echo we are so honored to be part of this panel and to thank the University of Nairobi for hosting us and the Mercury Solutions for inviting us. So my name is Deepa Risal Pokharel, and I come from a very small country, Nepal, where we boast of having Mount Everest, which all of you, I'm sure, would have heard about it. We are also one of the countries which was never colonized. That's the second thing that we like to talk about. But in any case, I'm the senior advisor for social and behavior change for UNICEF immunization demand team at headquarters in New York. So I have been working in the field of social and behavior change for the past 25 years in different capacities in different countries, including South Asia, Africa, and now in New York. And I was in Nairobi for 5 years, so Nairobi is home. It's great to be coming back home here. So I was asked to talk a little bit about the social and behavior change work that UNICEF does. So UNICEF has got presence in over 190 countries, where we have dedicated capacity and social and behavior change colleagues working to support the ministries of health and other areas of work that we do. So what we have been doing is, when we talk about social and behavior change, our area of work means that we work very closely with families and communities, partner with them, not just taking them as beneficiaries. So we look at what is the local insights that are coming in from communities, and then we look at the epidemiological data and how do you make sense of it. So our work in social and behavior change is really to help families and caregivers make decisions, informed decisions based on data, to look at what is the science telling us and what is the community insights telling them, to help them address some of the barriers they may be facing. We all know that there are great services, including for vaccinations, but it's not always the case that just because the services are there, that people would come and utilize or adopt the behaviors that we expect them to adopt. So UNICEF's team on social and behavior change work on understanding what are the barriers that communities are facing, what are the concerns, what are the perceptions that they have towards vaccination, for an example, and then help them address it with science-backed, evidence-backed interventions which would help them to create local solutions which we partner with them to implement and then to monitor at the end of the day, and to look at what are the interventions that really work. Sometimes what we do as communities who work on public health is we look at the overall big picture of what the epidemiology is telling us, but do not have the opportunity to really listen into why is it that the people are not coming in. So how do you make sense of the data which is going on? When you talked about the information environment, Jerry, I was just thinking about the different sources of information that people are exposed to, including the social media. After COVID-19, it has really gone up, and so how do you actually look at the social digital communication, the social data, what is coming in as community feedback, and try to triangulate all the data which is coming up so that we can work with communities to make sure that we are having more of the human-centered design approach to interventions which are very hyper-local and focusing on the more underserved and under-vaccinated areas and bring in the voices of the communities. Thank you so much.
Thank you so much, Deepa and team. I think we have a very diverse experience panel with the experience cutting across very interesting sectors. Just very briefly, my name is Gerishom Gimayo. I'm the Director of Health at the Rockefeller Foundation. The Rockefeller Foundation has been working on public health for the past 100 years. Most recently, our work on social and behavior change has been through our work during the COVID pandemic, including our partnership with the Research Council, where we worked with communities to understand the barriers that they were facing to take up COVID-19 vaccines, and then supported projects to implement, to increase vaccination uptake. At the moment, we are moving our strategy to addressing the determinants of health as it relates to climate change, specifically working at the intersection of climate and health. How does climate affect human health? What role does climate science play in terms of informing public health decision making, and including now programs like vaccinations in addressing vector-borne diseases such as malaria, what will be the role of such programs as we are thinking about climate change. So to open up our discussion, I will start with Deepa today, just to ground us a little bit about the current state of vaccination globally. UNICEF is a very critical player in the immunization space. You set the agenda and you help countries implement immunization programs. The broad immunization agenda 2030 envisions a scenario where everyone who needs a vaccine can access the vaccine that they need. However, we know that that is not the case, even where there is intent, even where vaccines are available, and sometimes that is a challenge. Sometimes we're not able to convert intent into actual vaccinations. COVID also did not help the situation due to the misinformation that happened, due to the disruption of services that happened, and a lot of backsliding in immunization coverage across countries. What is your reading on the current state of immunization globally? And we can also focus a little bit about what it looks like in Africa. Thank you.
Thank you, Jerry, and you've already identified some of the problems anyways in the challenges. So, as you said, UNICEF is the largest procurer of vaccine in the world, but we also have a very strong social and behavior change communication where we bring the communities together we support the ministries in the countries that we work in. So, you know, in the pandemic really disrupted lives in all areas of our work. But because we work in vaccination, narrowing down to vaccination, what we saw was after the pandemic, we saw the largest decline in vaccination coverage, which we had never seen before. It was at the level where we were 30 years before. So it was really serious. But then with the interventions from governments and the partners like WHO, UNICEF, CDC, Gates, all of us, we saw that countries started to recover. Some of the countries have reached the level which they were before 2019, like India, for example, Indonesia, Pakistan, some of the countries. However, the WHO UNICEF estimate of national immunization coverage, which is done on an annual basis, we saw some improvement in 2022, but when we looked at the 23 data, it's kind of worrying because it's stagnated. So we haven't seen much progress in the number of children who were missed out from the vaccination, which we call zero-dose children. Were actually increased by a little bit. And then if you look at the African context, which you referred to, Jerry, DPT-3 coverage in the Africa region from the 2023 WINIC data, the WHO UNICEF estimate of national immunization coverage data, WINIC, which we call it, it had the lowest coverage for DPT at 83%. So there's a lot of work to be done, for sure. And there are a lot of challenges that we see, for example, you know, so, and one of the things that I want to allude to, because this is a summit which is looking at data and science, is that we have done pretty well in terms of looking at epidemiologic data, the coverage data, because we've got systems in place. The HMIs, the Health Management Information System, or whether you look at the the demographic health surveys, they capture data quite systematically. So we are able to see what is the scale, the proportion, the coverage. However, it's not that easy to capture the social data, the behavioral data in a systematic way. There are many reasons for that. One of the reasons being the HMIs does not really capture our indicators. The second being because it's the social and behavior change takes a lot of time. So there are, of course, a lot of challenges, including the spike in misinformation and disinformation we saw during the pandemic, which has really not helped us to maintain the public trust. Using the evidence to develop the strategies, as the Vice Chancellor was speaking, data is as good as it is. It's not just for publication. If it's going to be used for developing strategies, that's what we want at the end of the day. So these are some of the challenges that we see, but also I think the investment from the governments, the domestic resources to be investment is not that easy. So we may have the data, we have come a long way from having no evidence to collecting data, but now we will need to move a step away to see how to use the evidence to really work with families and communities to design the interventions that would suit them. And it's very local. You cannot expect that one pair of shoes is going to fit everybody. So those are some of the challenges that we are seeing. We are in the right track, but I think there's a lot of work to be done.
Sorry, Abdul, you can speak a little bit about your experience with Wayne County. Deepa has talked about the fact that epidemiological data is available. You're an epidemiologist. How do epidemiologists use social science data to think about uptake of vaccines?
Yeah, thank you, Gary. So I want to pick up on a piece that Deepa put down, which is when we think about vaccine uptake, obviously we know that country context has a lot to do with it. In the US, counties like Wayne, which is quite a lower income, although very diverse income, but lower income overall county, have tended to have lower vaccine uptake overall. We're seeing quite similar trends in Wayne as compared to what we're seeing nationally in terms of rates not catching up. And the implications are, whereas we had enough vaccine uptake for MMR to be able to prevent very serious measles outbreaks, we're watching as the rates of uptake have dropped well below that. So we're at about 88 to 89%. We know that you need to have about 95% to prevent the kinds of outbreaks that we worry about. And our county literally just finished out a 400-person contact tracing investigation because of a case that we'd had. And thankfully, there weren't any secondary cases, but it's only really a matter of time. The challenge, though, is this. Epidemiologists, we're really good at looking at outcomes and exposures, right? Anybody who's taken a public health class, remember back to your epidemiology class, what are the outcomes and can you predict those outcomes via certain exposures? And the problem with that is that we're kind of biased against variables we can't measure, in large part because you can't publish them. And the challenge often in science is that because the currency of science is publications, we are inherently biased against the things we can't publish against, even if they're effective. And I was talking to my chief medical officer who directly oversees the division, and we've been talking quite a bit about how is it that we start to get out there on vaccines, as I'm sure everybody in this room has had that conversation. And for us, it's that 1.8 million people in our particular county, so the problem is somewhat bounded, unlike when you talk about it in a global perspective. But we kind of reached one conclusion, which is like the vibes aren't right. And when you're trying to talk about vibes, right, that is a distinctly immeasurable concept, right? But all of us feel it, right? When you walk in, you're like, no, the vibes aren't right, right? And you can kind of look to somebody and be like, yo, vibes off. And people get it. So the question is this: how do we move our science to be able to capture and measure something like vibes? And I think sometimes what happens is, in science, the tail wags the dog. Can you measure it? And if you can measure it, then it's the thing you need to be focused on. Versus, actually, maybe we should be thinking about how we measure things like vibes. Now, what is it about the vibe? And I get all of your science brains, like I heard the gears click, like, what is he saying, measuring vibes? But what I'm saying is, can we find indicators that try and get us to what is that chatter about a vaccine? Like, to me, it's when you walk into the barbershop and you're like, hey, so anybody here vaccinated? And then you start seeing the looks. People are like, my guy. How do you measure that attitude? Is there a way to do it, right? And I think that's the challenge in front of us, because really what we're asking is, I want us to understand what are the predictors of somebody going out and getting vaccinated. And I understand that when me, credentialed epidemiologist guy walks out there and saying, well, I believe everybody in this county deserves to be vaccinated, and you can come on over to our clinics, they kind of look at me and be like, vibes are off. So who are those folks that can have those conversations? What is the nature of the conversation we want them to be having? And then what is the thing we can do to facilitate that conversation? And I really hope that as we think together here, that when I go home, right, on that 20 hours that I'm gonna have to sit on an airplane, that I can sit down and be like, hey, I figured out how to measure the vibes. Or here's how we're gonna maneuver the vibes. And the last thing I'll say is this. I think one of the challenges that we tend to have is that we only, and I'm saying this from a government health perspective, we only show up on those problems for which either we are funded to show up or we think matter. And the problem that I think we have is that people like me don't show up in the spaces where people want us to be, but don't rise to conversations like this. So in the United States, y'all know too many people can't afford their medication. And so you can imagine a scenario in which somebody says, hey, my cousin can't afford their insulin, and they're a type 1 diabetic, and they need insulin. And where were you talking about insulin, which is a drug I know they need to survive, back before we had this whole pandemic thing? Now, you all of a sudden show up when there's this pandemic, and I'm perfectly healthy, and you're telling me I need to take a medication that you all just created like yesterday, and I'm healthy? And when my cousin was in the ER for the 3rd straight time with DKA, and y'all didn't feel like showing up then? And now you want me to take this medication? Yeah, no thanks. Vibes are off. So I just think we need to be thinking a lot more about the context in which our institutions show up or don't, and then ask, when do we show up when they know they need us? And then how do we show up when we're telling them that they need us? And I think that mismatch there might open up some things.
So thanks so much, Abdul. When I come to you, Viknesh, and going off of what Abdul and Deepa have said, you come from the tech sector just recently. I would say the tech sector is very advanced in terms of the data that it collects. You might actually even be able to measure the vibes that Abdul is looking for. So from your perspective, what does the information environment mean to you? What role does the technology sector play in terms of spreading and disseminating information? I think during the pandemic, social media got a lot of flack for spreading disinformation. And what do you think the role that the tech sector can play in terms of disseminating high quality public health information?
Thank you. I think companies such as Google, YouTube, extending onto sort of X and Instagram, play an important role, but albeit a role as part of a larger kind of infrastructure and set of solutions. So firstly, we can measure vibes. So that's one thing we do on the YouTube side. We can measure engagement. We can see where people are coming to for their content, where people are engaging in terms of comments, likes, subscriptions, shares, things of that nature. And that gives us a pretty unique insight, particularly from our end, as to where the world is going in terms of their information sources. But what this doesn't really tell us is how this translates into kind of knowledge recall, in behaviors, and ultimately health outcomes. And as pervasive as these social media platforms may be across all of our lives, these are avenues of data that we don't have access to, truth be told, because it's not within sort of media platforms per se. It's sort of within communities, within health systems, within academic research centers. So I think our role here is really to foster partnerships. I really hope that this will be like a key theme that comes out over the next couple of days. There is some data and some insights that we're privy to, but really it's not as meaningful if it's not coupled up against behavior change outcomes, and ultimately health outcomes. So yes, that would be my point.
So thanks, Vic. I think we've gotten a sense of the kind of data that you need to understand the problem in terms of what is driving behavior, what is driving people's decisions. When we want to look now at developing solutions, what we want to think about is what evidence-based solutions are there that then can help address some of these gaps that we are identifying. Is this process in existence in terms of coming up with solutions that are evidence-based, that address the information needs that people have? Does it actually work like that in practice? Maybe I'll hand it over to you, Deepa.
Thanks, but I wanted to pick on the two things that my colleagues have just said. So, Abdul, I think one of the things which has been really a challenge for people like us who work in social and behavior change is the advocacy bit, you know, and then it would be really interesting to, it was really heartening to hear from you and reflect about where you need to be, you are not able to go, and where you are not needed, you know, or it's a bias kind of. So I think that's something that maybe we could think about. How do we work with the, you know, people like Abdul and other policymakers who can make a difference and be a voice and champion for immunization? And for you, Vic, I think that, you know, we do have in UNICEF quite a number of digital channels that we use to collect data, but also to co-create solutions with people. But it would be very helpful to connect and see what is it that we can leverage from each other, you know, whatever is available from your side, and how we could serve, because UNICEF does work very closely with the ministry, and we do help the governments to implement either through civil society organization or through our partners who work in the ground, mainly through the Ministry of Health. So I think that we have an advantage. I'm sure that among us there are many colleagues who work in certain areas of work, and I hope the solution, the summit is able to actually look at some of connecting the dots with us. So what are the channels available to us, you know? So we do have the digital platforms as well. Like if I just think of UNICEF only what we are doing. So we have a platform called U-Report, where the young people sign up to be the U-Reporters, and they are our eyes and ears on the ground. So you can do a polling, you can ask them questions about whether they've seen vaccination. It can be used for all kinds of things, but just narrowing down for vaccination, it started in Uganda, in Africa. So we have got millions of U-Reporters. Like just taking, for example, we did a U-Report survey on HPV vaccination, which Madam Ann talked about, and it was with 400,000 population. They responded, which is quite a huge sample. So it was very obvious that they have low knowledge about HPV vaccination and HPV. So how do you then use this insight to co-create the solution? So we have another platform which we call Fundu, which creates an opportunity for young people to interact with each other, but also we co-create the content with them, and we are able to reach millions of young people to listen to what they are saying, but also to help them understand the content of it. We have we have our colleagues here, Angus and Surani, who've been working, and we worked with Professor John Cook from Australia to develop an app called Cranky Uncle, which helps us to demystify and identify what are the rumors and how do you track the misinformation, the wrong information, and help to inoculate them against the misinformation, if you like. So you can touch base with Surani and Angus if you have the opportunity later. We also do a lot of other face-to-face communication, like we've been using the human-centered design, which is an approach which works with community to do very quick, rapid assessment, inquiry to understand their problems and concerns, and then we identify what would we do then about it. So we work with communities to co-create the solutions, which is then getting implemented. But the challenge is how do you scale it up? Because it's very hyper-local, and what does it mean if you are looking at a large-scale intervention? So I think there are channels of community engagement that we have been working with. We use the digital channels. We also work with health workers. Sometimes we think that health workers are more on the service side, which is not, because they are such an important source of communication for us. So we need to build the capacity for them to understand how community engagement works, how do we support them with supportive supervision, but how do you engage with them to become a conduit between the technical content of the message and what the communities would understand. So those are some of the, if I think of the, 4 or 5 things, the community engagement, the social listening mechanism, which we help countries to understand, track rumors, misinformation, but also to look at the information environment where all the information is coming together and making sense of it to make sure that they are ready and are resilient to deal with any future pandemic, but also on a regular routine immunization programs.
So, that's hot. So I really appreciate what Deepa shared about all of these different platforms, and I think they're really important. And I want to respond to something that Vic shared. It's interesting because so much of what YouTube, Meta, X, they've become the water in which we swim in a certain way. And I think one of the challenges is that, as I have grown up through the evolution of social media, I think so much of the way we've thought about it is as a platform, right? Meaning it is an agnostic platform into which anyone can say what they want to say. And you can have some engagement, but you put it out there and it goes out to the masses. And I think the challenge that so much of the vibes are a function of the fact that social media is actually not an agnostic platform, right? And Vic and I, we've had a couple pre-conversations. So I think, they're doing God's work inside of the beast. But I do want to talk about the beast because the nature of social media, and I host a podcast and I have a YouTube channel, and in those spaces, I am very thoughtful about trying to create content, not just to move information. And that's a second order challenge that I don't think a lot of us in this space have adjusted to. Because in my government role, I'm very conscious of not making a mistake. Meaning, don't say anything that anybody could come after you for, either in tone, in style, or in substance. So it comes out as very government taupe, right? And everybody knows what I'm talking about. Whenever you see a government official talk, they use very muted language, often with a lot of jargon. Everything has been looked through multiple different ways, and it makes it boring. Like, by definition, when you hear a government person speak, you're like, my God. Right? And the challenge with that is it's bad content. And the structure of social media, the goal of social media organizations, not Vic, personally. Vic's goal is to make sure everybody gets vaccinated. I know that personally. However, the goal of Google, the goal of Meta, is to occupy as much of the rent share of your eyeballs and eardrums as possible. And in order to do that, they've recognized that there are certain things that humans want, right? We want to be feeling stuff. We want dopamine hitting parts of our brain because what's being said is either edgy or exciting or conflictual, right? There's a reason people do gossip, right? It's not really all that important except for like, oh my God, did you hear? So the point that I'm making is the way we've learned to communicate as communicators of this stuff is counterposed to the logic of the platforms that we're communicating on, which creates a really, really challenging scenario. So even as somebody who does this on the side as kind of a business, every week I got to step back and be like, all right, man, what are they doing on TikTok now? I don't dance so good, so that's not happening. How do I get my point across now? So I'm trying to take some evidence and I'm trying to wrap it into content. And that's ever evolving. So we're either asking the social media platforms to be like, hey, put your thumb on the scale for us, right? Because our stuff's boring as anyway, right? Or we're saying, how do we start communicating in a more interesting kind of way? And I actually think that that's A, hard to do on its own terms. B, we're at a disadvantage because science is complicated. You have to be able to listen to a lot of different stringing of thoughts, and that you can't do in a 60-second TikTok, right? And if you can, God bless you, please go do that. And then third is that the algorithms themselves tend to, right, be very good at advancing the goals of folks who are saying the edgy thing because they're disagreeing with us. You guys see what I'm saying? So I started out when we were talking about trying to engage against opposition. Meaning, if you know that the nature of the algorithm is such that it's going to bias information that particularly specifically disagrees with you because you're the person who represents so-and-so institution, science, university, government, whatever, then you actually have to start with the end in mind of saying, all right, like, A, I got to be that much more interesting, and then B, right, I've got to ask, what are they going to say about what I'm saying, and go on and hit it. Now, that's the problem, is that when you are engaging with opposition, by definition, you're not pushing your own message, right? That is, I mean, the first thing that they teach you in politics is if you're explaining, you're losing. But like, isn't that what we're supposed to do, is explain? So I want us to, I don't have an answer here. I know this is a solution summit, but I've been trying to do this for a long time. I don't have an answer except for like, be as engaging as you possibly can be. But I want us to understand what we're up against, which is to say, just going on and saying, hey, I heard from this person from the government and they're lying to you, is going to get more clicks because of the nature of the algorithm, because it's more interesting, because we like gossip, because we like conflict, than being the person in the government to say, hey, there's this really great vaccine and you should take it. So how do we work against that? And how do we engage that and see it coming and do so within the bounds of not inadvertently moving the opposition message? They're saying I'm a liar, but I'm actually not a liar, right? Like, well, the minute you say I'm not a liar, people are like, why do you keep talking about lying? Right? So I think it's an important conversation to be having, and I think it's really important, you know, that there are good people working inside these agencies and these organizations to be asking, okay, how do we kind of address this problem? But from those of us on the government and or public communication side, we have to understand what we're up against, and we can't pretend that these are just platforms and we can just kind of do our thing louder, right? Because they're very different spaces.
So just following from that, Vic, before you go, we've had the challenges that social media and these digital platforms create. What kind of safeguards are you putting in place, and what types of partnerships are you setting up with public health officials, with government, with institutions to help address some of these challenges that social media drives in terms of spreading misinformation?
Yeah. I think a point that Deepa made earlier is that there is no such thing as a one-size-fits-all solution. So to that effect, we do have an arsenal of different things that we do. I can speak particularly from the YouTube side. So what we do is we have a number of levers through which we raise high-quality information. And these are not based upon principles that sort of myself and some colleagues have made internally. It's all anchored upon principles that have been set forth by the WHO, the National Academy of Medicine, and other continental and local organizations. So one such initiative is around raising authoritative sources of information, knowing that it is kind of algorithmically impossible to verify every single claim in every single piece of content that is produced in real time. What we can actually do is provide credibility cues and badges around institutions such as the CDC, WHO, NHS, whereby when they publish content, it is very clearly demarcated that this is from a trusted health authority. And this goes into a special shelf. If one were to type in diabetes, say, you would actually see these are videos from trusted health sources at the very top. And again, these are sort of very slight, subtle behavioral nudges whereby you, as a viewer, you'll say, why would I go to like the 50th page when I can see a really nice carousel of content at the top? That's one such lever. We also do have mechanisms through which we can remove medical misinformation. So we have, I would like to say, perhaps the most robust medical misinformation policy in social media, updated yearly. That came about in response to the COVID-19 pandemic, but is not limited to the COVID-19 pandemic. So last year we were looking at sort of miracle cures around cancer, which is a particularly common misinformation narrative that seems to circulate across the world. And we have various different enforcement mechanisms. So we know that our violative view rate of such content is tremendously low. So if something were to go up, claiming these sorts of kind of miracle solutions, it's often taken down before a single person can even actually go and consume this content. And just to touch upon what Abdul mentioned earlier around the consumption of content, I'd love to double down on his point actually. People don't go to these platforms to consume information, they go there to consume content. There is a wrap around the actual kernel of information that sits at the heart of videos, podcasts, images. that is very, very important to embrace in this day and age. I think it's important to kind of understand the vibes, the zeitgeist upon which you're actually creating this content in. It's all well and good if you're sort of a professor in a white coat reading out the best Lancet kind of abstract, but it will not hit home with respect to the masses and the communities that we're trying to reach. So it's important to understand, you know, if there is a particular trend on TikTok, not to say that we should all start dancing, because I also suck at dancing, but if you can lean into that and actually understand that kind of the anatomy of what makes information content and what makes information interesting, you'll be doing a tremendous job in getting your words out to as many people as possible.
Thanks so much, Vic. I think as we come to the final 5 minutes, just take this moment to reflect upon the conversation. We have a room full of students and researchers. What will be your takeaway in terms of how they can contribute to this environment that we are speaking? What research opportunities are there? What evidence is there? What evidence gaps are there? How should they be engaging in terms of trying to find solutions, interventions, and strategies to address some of these challenges that we've been discussing?
Okay, great. Okay, it's always lovely to talk to the young people. So, you know, if I was to think of a few things that young people can probably do, one of the things that is coming out is that we do need to improve the risk perception about vaccination among young people. So please go out and look at the evidence which is out there. And as Vignesh was sharing with us, the trusted source of information, whether it's CDC, WHO, UNICEF, or most importantly, the Ministry of Health websites, go and fact check what is out there to look at the evidence, and based on the evidence, please help to spread the word and to engage with your communities, with your constituencies, with your friends, to talk about the importance of vaccination. Young people did a lot of work during the COVID-19 in myth busting. Like there are many examples, including from Kenya, where they have been ambassadors of immunization. We had polio ambassadors as well as routine immunization ambassadors, and they have gone house to house and talked to the communities about the importance of vaccination. So that's probably something that we can take it as a good example from Kenya. Indonesia has done quite a lot of it as well. India does, Bangladesh. There are so many different countries which are doing it. So the second part is, how do you then make the evidence so that you are confident that it is based on science, but communicate in a simple language to your families, to your communities, but you would also be a would-be parents in the next few years. So you can take this in a sustainable way to make sure that the children are vaccinated, but also important to think that nobody is missed out. Not everybody will have the opportunity to go to school and colleges, but there will be in places out-of-school kids and, you know, children, your friends. So please do reach out to them also to make sure that they also have access to information, and to look at what you've been able to do as your contribution to your community, to your countries, to your society as well. That would be my message to the young people.
I don't know if this term is used here, but there's a difference in the US. We call it being book smart or being street smart, right? I think sometimes when people get book smart, they stop being street smart. And I've always found that the most valuable thing you can do with your education is to continue to leverage it to around what you know from the point in your life or the people in your life that aren't in spaces like this. So do not allow yourself to lose touch with, right, the ability to be a great learner outside of rooms like this, a great observer of folks who may not have access to rooms like this. Because what tends to happen sometimes, I always tell my students that when you come into rooms like this, you start getting mismented. Meaning you spend all this time learning how to think empirically, and then you forget that most of the world doesn't think empirically. You like literally had to spend a lot of time to learn how to do it. And then we go out and we start preaching numbers to people, and they're like, what are you saying? And so don't forget that. So as you spend time in rooms like this and pick up these skills, they're incredibly valuable skills, but they're only as valuable as you can reinterpret and translate them into spaces unlike this. So don't lose touch of that, and make sure that you're constantly spending time in spaces where you're not surrounded by people who use a lot of big words, right? And the last thing I'll tell you is this: intellect is not about using big words to describe small ideas. It's about using small words to describe big ideas. So as you learn big ideas here and you learn big words, don't ever forget to use the small ones.
On a similar point, I would also echo sort of thinking outside the box, be creative, be ambitious. I think health messaging has always had this very sort of austere, traditional sort of perspective on it. Like, you know, it's done from an ivory tower, from up high, through pamphlets, through sort of very, for lack of a better term, quite boring sources. What we see is that being creative, putting yourself out there, if there are particular trends that you see in other information verticals, wow, there's this like particular creator on TikTok or X who's really popping off. What is it about their content that makes them so interesting? What is it that kind of draws millions of eyes? Like, you know, not everyone is into like cooking videos or dancing videos, but it's bringing more eyes than people would naturally sort of assume to be interested in those topics. Kind of like disentangle the qualities around how they deliver their information and try and imbue it into how we go about and how you go about communicating health information. Because I think intersectional content is the way forward. I think the way in which we've been communicating these important, as you say, sort of very difficult to understand health topics to date is only going to take us so far. So embrace where the world is going in terms of content and in terms of social media, at least for the good parts.
So thank you so much. I think in a nutshell, what we've had is let's be engaging, let's communicate simply, let's meet people with information that they need at the point that they need it in channels that they can access. So let's give a hand of applause to our panelists for the great conversation today. Thank you.
Okay, now you guys can stay in place. You can finally open your water. At the same time, I would now like to also bring Anna and Anne back up to join the panel. And I'm going to move us directly into the Q&A. So as we're so grateful to have a large proportion of a lot of the audience here being the University of Nairobi community, including the students. And we really appreciate those students that submitted questions as part of their registration. And so I'm going to use those questions to continue this discussion. So, are you settled? Oh. I'm going to keep myself honest on the time, keep ourselves honest. So, I was very delighted to see this question, and it came in different forms from Edgar, from Isaac, from Lucy, and from Christelle, so thank you. Of course, I am part of the Social Science Research Council, so I'm pleased that you asked a question about the social sciences. So this will be a little bit long, but that means you can pick and choose what you want to say. I hadn't quite thought this through. If you want to go down, you can jump in, or we can manage it. It can be a little bit lively up here. So, as I think the Deputy Vice Chancellor and other people have alluded, and we've started getting to here, you know, maybe we think about public health challenges in scientific terms. We need to develop vaccines. Maybe we have the logistics of delivering vaccines and other health products. Or we think about them in medical terms, the diagnosis and the clinical encounter. But acknowledging that that often dominates maybe how we think about public health, I'd like us to think about the role of social and behavioral sciences in actually changing health behaviors and outcomes. So turning vaccines into vaccinations, because we know that vaccinations save lives, not vaccines. And so to further refine this question, I'd like, maybe we'll just go down the line and then you can discuss a little bit amongst yourselves, to reflect on what you see, you know, where are the social and behavioral sciences currently in discussion around improving health outcomes, including the uptake of vaccinations? And where would you actually hope that it would be within different systems and other places? And perhaps if you can offer 1 to 2 concrete steps that might help us move from where we are, the way that the social and behavioral sciences and evidence from social and behavioral sciences fit into how we address public health challenges and where you would like us to be. So it's long, but that means you have options. Can we start with you?
Sure.
Okay, oh, okay. Yeah, no, it's a great question. Thank you guys for submitting that. I think one of the things that social behavioral science can do for us is just to remind us that many of our good ideas don't work, right? And so we spend a lot of time and money and energy investing in vaccination programs, right? And strategies like, even manipulating the algorithm. There's lots of things that we're doing. And many of them sound like they will work in terms of increasing vaccination uptake. But one of the things that, when you run a research consortium like the Mercury Project or, any kind of research consortium in social behavioral sciences, a lot of them don't work. And that's a really important thing to find out because we're spending a lot of money and time and energy, right, on these programs. And so simply evaluating whether what we're doing is working is so important because it allows us to redirect our resources to things that do work. And particularly in a case of something like vaccination, and Vic made this point that, we need to know whether privileging trusted, authoritative health sources on Google is it actually impacting health outcomes, right? Because presumably we're also giving something up in doing that. And there's ways to do that, but that's the kind of work that we need to do, with UNICEF, with Wayne County, is working with them to figure out what are some cost-effective and feasible ways for us to evaluate this. And I would also say, the last thing also, you said a concrete step. This is easier to do if we work together before the thing is deployed, right, or rolled out, because we can always figure out a way to structure the rollout or the deployment such that we can estimate the effects. But when it was, we implemented a program a year ago, in our county, and everybody was eligible in the county, and now we want you to come and evaluate it. That's really hard, but talk to us ex ante, and I think that we can help.
Thanks, Anna. So the way I think about it is when we are designing medical interventions, we are not designing them in a vacuum. We are not designing them for people who live in a vacuum. People live in communities, people have networks, people have, they get information from different sources. By the time they're interacting with the health sector or these interventions, they have 10, 20, 30 other touch points. And we need to understand how those effects play out, what information is trusted and by whom, and how that information is delivered, as we try to think what is the best way to design interventions and then to communicate about those interventions to people in communities. So yeah, those are my thoughts.
Thank you. I guess I'd like to make a brief point.
You can address, you don't have to talk to me.
Sorry. Hone in. I'd like to make a brief point around this concept of ecological validity. Like, we see lots of studies which are designed for a very certain population that can prove out or disprove any element of sort of efficacy of a particular intervention. But then, particularly as we sort of see it at Google and YouTube, these things rarely hold true as when applied at a global scale. So I guess what I'd love to see is more studies that take into account kind of diverse cultures, diverse opinions, and whether we could do more to actually co-design and sort of build out mega studies. We're starting to see new methodology of mega studies going forwards. It would be lovely to see more and more of those applied into the preventative health space.
I really like the question. We medicalize health, and when you actually think about what that means, is that the bias around health is what one individual can do for another individual. And I think the real movers in health have a lot more to do with public policy, and public policy is downstream of or upstream of a lot of thinking about how we relate to each other. And I think one of the words that's come up quite a bit in our conversation has been the word trust. And I think the fundamental challenge of our time is the way that we are atomizing and the implication that has for trust in one another, in institutions, in policymakers. in quote unquote trusted entities. And trust is this thing that exists. It's like vibes. It's a vibe. It's like, are you in a space where you feel safe? And so much of what I think should be powerful about how we do science, we miss out on because we're thinking about individual level variables. We want to know, does this X work in this Y way on these individuals? And I don't think that's the right way of thinking about it. I think we need to be thinking about collective dynamics. I think we need to be thinking about emergent phenomenon. I think we need to be thinking about the kinds of complex interactions that exist in a real society. And the beauty in this moment is I think social science is starting to capture and engage with tools that allow you to think about some of this like emergent substrate around us that I think is so important to the circumstances in which we live, whether you're talking about whether somebody takes a HPV vaccine in Kenya or if somebody decides to take a measles vaccine in Detroit. And I really want us to be thinking about some of these ecological and or complex phenomenon and really starting to measure and ask, what is this, how much of this substrate is there? How does it affect all these other institutions? And how does it shape choices? I think that's where the gold is going to be.
Thanks, Abdul. So just reflecting on what other colleagues have said, I think one of the things which is very important for us is to put the community at the center of everything we do. Not as recipients, but as partners. Families and caregivers, we should be partnering with them on equal level. And I think if we start looking at what is coming out as the social science, behavioral science data, and understanding the drivers of why they want to go for vaccination or why they don't want to go for vaccination, if there was an understanding combined with the data that we are seeing in coverage and why it's going up and down, I think that would help us a lot to make informed decision. But when we talk of data, the second point I wanted to make is subnational data is a scarcity and a disaggregated data. So we do need to look at different personas about who are we really looking at. There are tools which have been developed. We have come a long way from the time where there was no evidence to where we are collecting data. There are tools available which are standard tools, but these need to be applied at different settings, adapted to fit the local needs, so that we can work then with the communities, with the young people when we are talking about HPV vaccines, because they are the decision makers at the end of the day to say what is going to work for you in your context. So the environment really matters because there are so many different sources of data that is going around. But how do you make sense of everything which we are looking at? We need expertise, we need organization to invest in social and behavior change. I always find it very strange that we always have money to invest in the supply side of it, in the vaccines. What about the communities? What about the social behavior change interventions? It does not come free all the time, But this is the mindset that, it's only about having the supplies, the syringes, if they are there, the people are automatically going to come. But that's not true, because there are going to be new cohorts of parents every day. So I think we need to also think about investment when we think about the social and behavior change. Thanks.
Thank you. When I think about the role of social science in for example, vaccine, I think of social science, if I may borrow the earlier conversation about the science of the vibes, that really social science is in the social labs, it is out in the communities, it's the everyday happenings and everyday interactions. So we will not go to a lab to study social behavior, human behavior, so we have to observe and listen to the communities, and we observe. And then from there, then we know really what is the reality that we need to study. When you think about the vaccination programs, for example, many times they are top-down, donor-driven kind of programs. How can we revise that trend to make it more of a community-driven process? That is actually the communities that are driving the vaccine programs themselves, that it is not the government that is telling us we should go and take the vaccine. So that if at one point we don't trust a government, then we don't go for the vaccine. We go for the vaccines depending on the friendliness in perception of the government that is pushing the agenda or the organizations that are pushing the agenda. So for me, what I would want to see is a reversal trend where we see communities driving the process themselves. So that means working more with the communities. And also to note that misinformation is information itself. Why are people depending more on this misinformation? And what proportion of our population are actually depending on this misinformation and reacting to it at the same time? Thank you.
Great. I think we have time for one more question in this round robin. And of course, we're at a solution summit, so I'll ask you to be solutions-oriented and perhaps tight in your response. So Daniel asked about the role of evidence, and I'll refine this a little bit more. I think maybe we all have some idea that we want decisions taken in public health and in other entities that affect health outcomes to be evidence-based or evidence-informed. And so thinking about, we probably want evidence to help us define the problem so we target our resources correctly, to identify possible cost-effective solutions, and then to help us solve implementation challenges and know whether the thing worked. So we also probably believe that there's not enough evidence being used in a lot of these decisions. And so I'll ask you, as we go around, maybe one challenge that you see to using evidence in the decisions that you need to make, given the different hats and roles where you all sit in, and then one idea of how we can maybe break down that barrier. Should we go in reverse order? Okay, will you start? And then just to be clear, then what I'll do is everyone, after we answer this question, will leave the stage. I'll ask Anne to make some closing remarks, and then Anna will close the summit, and I think we'll be right on time.
Thank you very much. I think I would use the example of the HPV vaccine, which perhaps I'm more familiar with, or even the malaria vaccine itself, which perhaps is yet to reach to the masses. And I think the biggest problem is what I see is the main challenge is that the people that we target with the vaccine perhaps don't even understand anything about the vaccine itself. So we need to really improve on information sharing, because otherwise there'll be other people who will come and give the same information. The HPV vaccine, for example, has been surrounded with a lot of religious misinformation. I don't say misinformation, maybe also I'm using the wrong word. But the real target, the young people, I'm not even sure that the girls even understand what is HPV. The word itself is too big, even to pronounce, when you put it in the full word, to even understand it. So how do we break down that information to the right people and with the right people, so that they really understand, first and foremost, where they need to go for it? So that it's not just the ones in the healthcare system that are pushing for it, but really the target populations. That's what I would say. Thank you.
Thanks, Heather. So I'll just focus on the part that you talked about, what is the challenge in using evidence. So I think there is data out there in many, many countries, all kinds of data, from quantitative to qualitative to social listening, community listening. And what we are hearing from countries is that we're really struggling to bring everything together. And how do you make sense of it? So that's the biggest challenge that we are having. In terms of capacity, so that's the challenge that we have, to understand the data and to make sense of it before they can use it. Because there are hundreds of recommendations, it's not going to help. You need to come up with prioritized 3 or 4 recommendations which are doable, which are actionable. So that's something that we are really struggling with. So the Tuesday and Wednesday, we were collaborating with Africa CDC, WHO, and UNICEF, had brought 10 countries from Africa together for a capacity building on social data and social listening. So that was very, very useful. So I would think that in terms of what we can do to solve, what would be the one solution that we could propose is definitely in-country capacity building for them to understand. Not everybody is going to be data scientists, but let's bring in diverse group of people from monitoring, from health promotion, from the EPI people, so that they can all understand and advocate for the importance of data and using the data. But also, I think we need to be at the systems level. It doesn't help if social scientists are doing their own thing and the program colleagues are doing their own things. So I think if we are able to be on the table when the situation analysis is being discussed, or when they're identifying the objectives and whatever, and when I talk about the system, Ministry of Health is very important, yes, because we're talking vaccination. But let's remember that there are other ministries like Women and Children's, there are local development, depending on the country's context, right? There are education system, who we need to work with and share what is coming out as evidence. And let's not forget, last thing, can we please share the data with the communities where we've collected the data from? That does not come naturally to all of us, but they would see the benefit that this is what is coming from my community. I need to do something about it. Thanks.
Three pieces. I want to pick up on what Deepa said. Number one, data informs different pieces of a full puzzle, and there's a lot of time spent on new learnings, but not a lot of time synthesizing that data into this is what we know, right? There's the ideas of the different pieces of an elephant. All right, so this is the whole picture of the elephant. This is what we have really good data on. The rest of it you got to fill in. The second part of it is we don't really, that point about transportability of data is really difficult. So you may have data that is contextualized in some community and folks are like, you should apply this. And you're like, well, I'm working in a different community. So I don't really know how legit this is in terms of its transportability to this community. The third is, and this is the one that I think is really tough, and Deepa made a really great point about it, is program development is really hard. And there's a lot of contingent pieces that go into like hiring people, then firing people, then getting a program funded, then making sure you deploy it, then learning from. So once you get new data, it's really difficult to pivot on a dime because it takes years to put these programs together and a lot of bulky maneuvering. So what I think is helpful is to say, how do you turn every program into its own data collection engine that is getting and then rethinking itself and self-learning? And then how do we turn that into a part of being able to take and pick out from what we know about that elephant? And I think those pieces need to be thought through.
Thank you. Again, just to double down on what members of the panel have already said, we only ever see one piece of the puzzle when it comes to the amount of data and insights that we can glean. Understanding things like metrics such as views, likes, comments, gives us an idea as to how people are using this content and information. But as clinicians within a larger tech company, it doesn't really give us that sort of sense of fulfillment to know that it's led to behavior change and an improvement in outcomes. So creating a pipeline, both locally and perhaps sort of more on a continental, perhaps even global scale, of understanding how a piece of content on a platform can ultimately drive meaningful change would be a North Star goal that ideally all of us should be aspiring to. So both a challenge and hopefully a solution somewhere there.
Thanks, Vic. And mine will also be to echo what my colleagues have said. I think one of the challenges that we see is the breakdown between evidence to policy. So who's driving the research agenda? Are those the questions that policymakers have? Are those the questions that program managers on the ground have? Are you answering the questions that will actually help them to make the right decisions at the right time, at the right cost, to drive forward their programs, any iterations and improvements that they need to make? So I think closing that divide between what evidence is being generated, for whom, and why it's being generated is important.
Thank you. Well, you asked us to answer the question from the perspective of kind of our own institutional context. So I'm going to talk about universities. And one of the challenges that we have in universities are all of our faculty, colleagues, and our students who aren't in rooms like this. The university system does not always provide the right kinds of incentives or encouragement to faculty and students to do exactly the kind of work that the panelists here on stage are asking for, to enable research projects to be defined by communities, right, or by government agencies, or by NGOs, as opposed to the researcher sitting in her office deciding, like, oh, this would be a really interesting thing to ask, right? And so I think from our end, on the university end, for all of you who sit in the room sitting in leadership positions in universities, we need to figure out how to make more of those connections between our research faculty and the people who need research help.
Thank you so much. So now, panelists, if you don't mind staying, and then Anna, if you want to come and halfway close the door, and then Anna, you can close the door all the way, and we will be done.
Thank you once again. And again here, on behalf of the IDS Director, Professor Paul Kamau, the IDS and the University of Nairobi, and of course not forgetting the Arua Center of Excellence for Non-Communicable Diseases. I think mine is to really appreciate everyone for being here and to say that this is really a great opening session. Do really sincerely thank the SSLC, the IDS planning team, the panelists, the online participants, and the ones that are here in person. We really, really are greatly honored to be here and to have to hold this summit here in Nairobi, Kenya, and at the University of Nairobi. It's a great honor. As I close, maybe just 2 or 3 issues that I may want to pick is that the issue of vaccination, of course, is a global health issue. It is something that needs a lot of attention in terms of how we address global health issues across the world, in the context also of climate change and what we are seeing now in terms of the climate change debate. It's about capacity building. So the young researchers, the young scholars, the students, masters, across the disciplines, I am sure you can find a place for yourself within the vaccination debate. And there's never a fixed topic or a fixed discipline that can be studied. So I think we encourage our students to engage more and to reach out and to also be part of this summit. Of course, we need to work across disciplines. We need to address issues of data collection. What data do we want to correct? How, from who, and how do we package this data? I think it's an issue that has been raised here, and it's something that we need to think about going forward, even as we think about the vaccine programs. Also, we need to think about how do we integrate vaccine research in other global health aspects. The concept of One Health is one that we need to think about. How do we fit vaccine here, vaccination in that, and the whole health concept approach, again, is something that we need to think about. So from the IDS side, I would say that I'm very, very grateful. And I would say that as we continue to engage, we hope that this partnership will be solidified even more, and that we bring also other partners on board. So allow me to stop there and to say we are really honored and we are very grateful. Thank you very much.
Thank you, Anne. All right, so the thought that I want to leave you with is one of my favorite ways of thinking about human history, I guess, and human progress. It's from my colleague, my former NYU colleague, Paul Romer, who's now sadly since moved on. And I think as many of you know, Paul wrote about and won the Nobel Prize for the insight that the most remarkable advances in human well-being have come not from discovering new natural resources, but rather from discovering new ideas about how we could use those resources to more effectively, more efficiently make the things that we need, the things that we value. And what Paul is talking about is precisely things like ideas for how to make vaccines and how to make them efficiently and how to get them distributed. And that's absolutely true that the money that we've invested in vaccine discovery and production and distribution have been well spent, and we should spend more. But I think what this conversation this morning has raised is that we need more and better ideas about how to convert those vaccines into vaccinations, right? And we need to maybe invest more in that kind of medical research or health research. This is something that we're working on actively in the United States. There's a coalition of funders that are medical research funders that are putting a pause on their medical research funding to think about, are there ways that they could better support things like prevention and including vaccination. So just an optimistic note that I think we're starting to see increased attention to the importance of funding this kind of work. And so with your help and your participation, hopefully we'll get somewhere. Thank you all for joining us this morning. I hope you've enjoyed the conversation. I hope you've learned something. And we look forward to working with all of you moving forward. Thank you.
Okay, so a bit of stage direction. It's sort of anticlimactic after that to do this, but officially closed. So students and members of the University of Nairobi, community on your way out, please pick a notepad and a pen, and there's a snack for you. And then folks that are staying for the longer workshop, please, if you have a clipboard, that's you. Please make your way to the 5th floor for our photo.